Bismillah ar-Rahman ar-Rahim. Thank you everyone for joining us today. My name is Dr. Ibrahim Jalaidan. I'm here today in the behalf representing the Saudi Heart Failure Working Group with my esteemed colleague, and we're happy to start the series of webinars that inshallah will continue for the rest of the year. It's all going to be CME accredited webinars. So please follow us on social media at the Saudi Heart Failure Group Working Group to attend the next few webinars. We're going to be talking a lot about all heart failure aspects from medical therapy, HFpEF, cardiomyopathies such as amyloidosis, challenging with medications, stage A, stage B, cardio-oncology. So we're going to have a lot of multiple events, inshallah, in the future. This is the first one. And I'm very happy to share the podium with the esteemed group of my colleagues who are all share the love of heart failure and heart failure therapy, which is a growing problem in our community with around almost maybe 500,000 or even more Saudi patients currently. And it's a growing issue, especially with the increase of the risk factors, the age of our population. So we really need to identify this disease early and treat it as best as we can. So without delaying the speakers, I will start with my dear friend, Dr. Ismail Raslan. He is the Vice President of the Saudi Heart Failure Working Group, and he is also an assistant professor at King Saud University, leading the heart failure or heart function unit. And he will be talking to us today about the heart failure with reduced ejection fraction. What are the latest guideline updates in 2026? The floor is yours, Dr. Ismail. Unmute you. You're muted, Ismail.
Assalamu alaikum jami'an. Thank you very much, Ibrahim. It's my genuine delight to be here to give this talk. Can you confirm that my slides are showing?
Yes.
Perfect. So to start off, I was asked to tell you, what does the guidelines tell you about the management of heart failure, and what is the most recent update? Well, basically, as we stand right now, the best reference for us is the American guidelines when it comes to the management of heart failure. I mix and match between both, but primarily you're going to be listening to the American guidelines as we move forward. We know that heart failure is here to stay, and if we look for statistics in the United States, there are about 6.2 million people currently living with heart failure, and every year another million is expected to come in. And there's 1 in 9 deaths that are resulted from heart failure. It's a very expensive cost on the medical health system, with over $30.7 billion in cost. And the mortality is essentially a flip of a coin after 5 years of a diagnosis of heart failure, irrespective of the ejection fraction. And as we said, the lifetime risk really varies on where you are and what kind of resources are available for you. But one thing is clear is heart failure is here to stay, and these numbers are expected to increase over time. And irrespective of gender, the older the person is, the more likely they are to develop heart failure in their lifetime. And aside from gender and age, demographics also plays a very important role, and that's why the guidelines also emphasizes social determinants of health. So sometimes your zip code, your skin color, where you are actually affects the incidence of heart failure in the 1,000 person years. And there are certain things that are unique to our population. So if we look into the heart failure registries in Saudi Arabia in reference to other registries, you can tell that our population is younger. We have more diabetes and more hypertension, and essentially we are carrying more risk factors with a younger age group in reference to other registries. And one thing also stands out is the longer the patient lives with heart failure, the more likely they are to be hospitalized. And the longer they live with heart failure, the more likely they are to die. Despite how morbid that is, it's important that we take home these key messages because our interventions carries output for our patients. So this is a case from our heart function unit in the university for a 52-year-old male who has ischemic cardiomyopathy, PCI 2 years ago, obese, diabetes, not well controlled, no CKD, and no prior heart failure clinic follow-up. So this was his first presentation to our clinic, symptomatic NYHA classes 3, orthopnea using two pillows, PND, and reduced exercise tolerance. And he tells you, I can barely walk a flight of stairs. On his vitals, he has a good blood pressure. His heart rate is 96 in sinus rhythm, and he's on room air, as we said, obese, overloaded with a JVP that is high and bilateral kidney edema. A BNP is 4,800, a creatinine is 100, GFR is decent, and essentially your potassium and your sodium and your hemoglobin A1C is as you see. And when it comes to the cardiac workup, his LVF is 25. You have a dilated ventricle, no significant MR, and your ECG is sinus without a bundle and a QRS of 100 milliseconds. His current medication is perindopril 4 milligrams, metoprolol titrate, and furosemide. And I can tell you, for a heart failure doctor, this patient coming to your clinic, these are the things we actually enjoy. But low key, you're a little bit upset because there is a missed opportunity here and not only one, but there are several missed opportunities. So I'm going to pause here for 5 seconds, and I just want you to think in the back of your mind, what can I do differently for this patient? And at the very end, I'll tell you what we've done. But as we mentioned, for a heart failure doc, as a first presentation, this is basically what we want to help with and what we want to assist with. This is by far the heart failure doctor's most favorite slide. You know, a picture tells 1,000 stories, and this is it. And I think I use this in all of my presentation because at the end of the day, your patient has two main things, their quality of life and the intensity of care. So think about somebody around you or yourself. God protect you. You've never heard about heart failure. You've never had heart failure before. So essentially, there's no intensity of care. You've never heard about these interventions. You haven't needed them. And your quality of life is at the very top. So excellent quality of life. And then what happens is you have an onset of heart failure, and then your quality of life takes a dip, but also the intensity of care goes up. And that never reverts back to normal. Albeit, if you're talking about a reversible cardiomyopathy, maybe we can talk about that later. But life is never the same for this patient. There's always this confounding risk of sudden cardiac death, repeated decompensation, and then the patient reaches the point of no return. And that is the thing that we try our very best to avoid. It's very important that we speak the same nomenclature, and this is what the guideline tells you. So stage A is patients that are at risk. So if you're in a general family medicine clinic or a general cardiology clinic, these are the patients who have risk factors, and we have many of them. Stage B is patients who have evidence of dysfunction, but they are asymptomatic. So an EF that is truly low, but no symptoms, no BNP elevation. Stage C is your patients who are symptomatic, and stage D is advanced heart failure. And we're really going to be focusing more on stage C because stage C has these four trajectories. Either it's new onset or de novo heart failure, resolution of symptoms, or persistent heart failure, or worsening heart failure. And that is the thing that you need to account for. And most importantly, you have to keep in mind that there is no going backwards. Once you are in a stage, you're bound to that stage. The guideline also tells us it's very important that we do a good history and physical examination. So it's very important that you get the vital signs. You have to look for congestion at each encounter, evaluate the presence of advanced heart failure. You need to get a good 3-generation family history, looking for inherited diseases, and basically using your history and physical examination to uncover other specific disease diagnoses. Also, you need to identify cardiac and non-cardiac diseases with lifestyle behavior factors, and again, the social determinants of health. These are the basic investigation. You cannot work a patient up for heart failure without making sure you have a CBC, urea electrolytes, serum creatinine, BUN, glucose, lipid profiles, LFTs, iron studies, and a TSH. You need to get a 12-lead ECG, and basically you would add more testing depending on the patient. So as you've gone through with this, the next best step is a pro-BNP, and that's what all the guidelines tells you because it's a very good rule out test if your patient is having symptoms, but that is an add-on to your history and your physical examination. So based on that, you would do your pro-BNP, and if your pro-BNP is high, then you have a very suggestive case of heart failure, and this would be later followed by a transthoracic echo. And based on the echo, you would decide what is your initial classification, and thereafter you would do your serial assessment to decide if your patient is improving or in the same class or need to be reclassified. The guideline also tells us that you need to get a chest x-ray for your patients, especially if they're coming into the emergency department. You want to make sure you're not missing another cause for your patient's shortness of breath. A transthoracic echo is also a class 1 recommendation, and other diagnostic tests depends on the case by case basis. So, for example, in patients whom your echo is inadequate, using another modality to better evaluate ejection fraction, such as a cardiac MRI or a nuclear study, can be utilized in these patients. Other things that you can be considered is an MRI in general for patients with reduced ejection fraction, but again, that's not a class 1 indication. Ischemic evaluation, despite it being presented as a class 1 indication, is not a class 1 indication, and it's a class 2A, but that's really our common practice. And essentially, that is the main thing that you need to do, and you need to tailor your tests based on your patients. I'm not going to spend a lot of time on stage A and stage B, but essentially, in stage A, these patients are at risk. You really focus on the risk factors. And at that point, screening with a pro-BNP is not a class 1 because ideally this patient has not developed symptoms. Now, on stage B, what I really want to focus on is there are no ARNIs in this population right now. We're talking about ARBs and ACE inhibitors in this patient population, and that is also guided by your patients. When you're talking about heart failure with reduced ejection fraction, primarily stage C, the class 1 indications are as follows. So you need to put your patient on an ARNI if they are NYHA class 2 to 3, and then you would consider a beta blocker, an MRA, and an SGLT2 inhibitors and diuretics as needed. Class 1 is essentially to alleviate their symptoms. You would then look again to see if your patient is improving their ejection fraction more than 40%. And if they are, then you would continue your education and you would continue with the goals that we have discussed previously. But if your patient is not improving his ejection fraction, less than 40 still, then there are other things that are available for you. So if you're still NYHA 3 or 4, African American, you have a good blood pressure, then adding hydralazine nitrate is possible. If you have an EF that's less than 35 and NYHA class 1 to 3, then ICD is considered if you're likely to survive for more than 1 year, and then consideration for a CRTD. Thereafter, if you are still symptomatic, then at that point you're likely in stage D refractory heart failure. And at that point, you're left with MCS, whether it's temporary or durable, cardiac transplantation, or palliative care. Now, our medical therapy is pretty good. And if you look at this paper, it shows you that for a patient that is 55 years of age, if you put them on comprehensive therapy, so quadruple therapy, you're adding 14.7 years for this patient. So that's an added 8.3 in reference to somebody on conventional or triple therapy. And the same is also seen, but in a lesser magnitude of somebody that is 65. And, there's this impression that we love to give medication, but it's really for the four main things that we're going to talk about because we've been through these major paradigm shifts, and the pun is intended. And our understanding of the mechanisms behind these medication has also evolved, and we've been more strategic and more targeting. But in the end of the day, these four pillars on the maximum tolerated dose that you can give is going to give us four things. So we're hoping that we improve your symptoms. We're hoping that we decrease hospitalization. We're hoping that we would at least stabilize or much better improve ejection fraction. And lastly, we're looking to decrease mortality in these patient population. And you need to really appreciate the fact that the number need to treat is very low for these medical therapies that are available for us. They're very impactful, but they're also very cost effective once initiated for your patients. Despite that, we still appreciate that there's this inertia not to give GDMT or not to maximize GDMT. And if you look at a population of patients who are eligible, 82% of those who are eligible, only 41% were on triple therapy, and only 15.3% of these patients have been on quadruple therapy. And that's a missed opportunity. And I'm sure in the first slide that we presented, you've all picked up on the things that should have been done or things that should be done in this patient encounter. And you really have to appreciate the absolute risk difference that you get from being on quadruple therapy in these patient population. The second question that emerges is great. So how can I get to quadruple therapy, maximally tolerated? Historically, there has been more than one way. And, the conventional sequencing is no longer popular in the sense that you would start a RAS inhibitor, maximize it, go to the second one, and then the third line, and then the fourth line. And that's going to take you up to 6 months. Things went even further to a sequencing algorithm. So beta blocker, SGLT2 inhibitor, maximum dose, and then RNA, and then MRA. And you can get to that in 4 weeks. But what's also new, or relatively new, is the STRONG-HF trial. And the STRONG-HF trial looked into randomizing patients one-to-one, 1,000 patients, to usual care or highly intensified care, in the sense that the patient, before they leave their hospital, they are put on half dose of maximally tolerated therapy. Keep in mind that this trial did not have enough SGLT2 inhibitors because it was making its way through, but discharging them on half the dose, and then within 2 weeks, you get your patients on full GDMT or full maximally tolerated GDMT with frequent follow-ups thereafter at 90 days and 180 days. What this trial really showed that all-cause death and heart failure hospitalization was statistically significant, p-value of 0.034 in those who had basically early initiation of GDMT. And essentially, mortality has not been statistically significant. But really, the take-home message from this is starting and up-titrating GDMT in hospital is safe, and it's actually beneficial. Other things that can be done is remote patient management through remote monitoring. And that's one of the things we pride ourselves in our center being able to do, because that also opens another avenue and is associated with improved outcomes. Thereafter, the guidelines tells us it's very important to make sure that does your patient need a device and what kind of device is needed. So if your patient is NYHA class 1, EF is less than 30, ischemic, and the left bundle more than 150, then at that point you can consider a device. If your patient is NYHA class 2, ambulatory, left bundle more than 150, then a CRT is indicated. And then there's also focus on other indications that are beyond the scope of this talk. Other additional therapies that should be considered is surgical revascularization. If your patient has severe secondary MR, then the most important thing at this point is to make sure that you've optimized him before considering any kind of mitral intervention, because a lot of these patients, once remodeling starts, once your left ventricular diameter improves, your MR also improves, consideration can be made for transcatheter edge repair, and essentially considering other type of wireless remote monitoring, such as CardioMEMS, is a class 2B for these patients. The guidelines also emphasizes on the need of a multidisciplinary team management once you're looking at these patients, and also making sure that they don't have atrial fibrillation. And if they do, then you would consider not only a rate, but a rhythm controlling strategy. You need to also ensure that you screen for iron deficiency anemia and also for obstructive sleep apnea in these patients. When you're looking into CardioMEMS, this is the CardioMEMS device. The guidelines suggest that it's useful to consider in these patients who are high risk of rehospitalization. The guidelines also tells us that we need to consider exercise and functional capacity testing for these patients, such as 6-minute walk test, a CPET test, and also cardiac rehabilitation. There's a big emphasis on disparities of health and vulnerable population, most importantly, because once the patient comes to you, the most important thing you need to ask yourself is why is the patient coming back again to the hospital? Is there something that we can adjust for? Are there social determinants of health that are preventing this patient from taking his medication or her from coming in to follow up? It's also important to realize when advanced specialty referral is needed. And it states that in patients with advanced heart failure, when consistent with patients' goals of care, timely referral for heart failure specialty care is failure management and to assess the ability of advanced heart failure therapies such as LVAD, left ventricular assist devices, cardiac transplantation, palliative care, and palliative inotropes. And the important thing is a complete assessment is not required before referral. And after the patient develops end organ dysfunction or cardiogenic shock, they might be no longer qualifying for advanced heart failure therapy. So there's this golden opportunity where an investment in the patient hopefully will result into meaningful outcomes. So the I need help algorithm or acronym is a very helpful one. So I is for I need for intravenous inotropes. N is for New York Heart Association, class 3B or 4, persistently elevated nitric peptide, end organ dysfunction, a low EF that is less than 35%, defibrillator shocks, more than one hospitalization, edema despite escalating diuretics, low blood pressure, and prognostic medication intolerance of GDMT. Taking you back to our previous case, at the 6-month mark, when the patient came to follow up in the clinic, the demographics did not change, but the symptoms markedly improved. The NYHA classification became class 1. There was no longer orthopnea or PND. That was previously 2 to 3 times per week, and the reduction in exercise tolerance has also resolved. If you look at the vitals, the blood pressure is still good. We started off by 126, if I remember correctly. Heart rate was in the 90s, and it's down to 62. And the weight is 99, so he lost about 13 kilograms. JVP is low, and there was no lower lymphedema. What we're going to hear later from Dr. Osama is what if this patient has a heart rate of 70 or 80 or 90, despite being on maximally tolerated therapy? You can tell that the NT-proBNP has also went down. The creatinine is actually better, and the EGFR is better. The potassium is slightly elevated, and his hemoglobin A1C is better controlled. So what has been done? So the echo showed that the EF improved, and the ECG is still the same. But at that point, this patient has been switched. He was on an ACE inhibitor, and now he is on sacubitril valsartan on the maximally tolerated dose, on a maximum dose of bisoprolol. Again, he was on metoprolol titrate, and an evidence-based beta blocker is bisoprolol, metoprolol succinate, or carvedilol. He's on spironolactone and dapagliflozin at 10 milligrams daily. Additional interventions that were undertaken in this patient is a diagnosis of OSA was made. So CPAP was initiated. He was enrolled in cardiac rehabilitation. There was structured weight loss and diabetes optimization. And also, he was found to have iron deficiency anemia, which required which required iron replacement. And then at this point, this sets the stage for my colleague, Dr. Osama, to tell us about the other non-class 1 interventions for heart failure with reduced ejection fraction. Now, in conclusion, heart failure is here to stay, and we must be comfortable managing it. GDMT quadruple therapy is essential, and it's important that we start early and titrate to the highest tolerated dose. don't overlook non-class 1 indications because they add meaningful benefit. And most importantly, my takeaway has always been that when in doubt, refer early. It's always better early than late. Thank you very much.
Excellent, Dr. Ruslan. Excellent lecture as usual, summarizing the importance of heart failure with reduced ejection fraction, and the current guideline updates, the quadruple therapy and its importance and of saving life, and how much we're doing in terms of the compliance with those quadruple therapy. And I think that's going to be a discussion point at the end. And I think for the sake of time, we will keep the question at the end all, so we have probably a better lengthy discussion with a good flow of thoughts. And for the people who are attending, we're almost 270 people. If you have any question, please put it in the chat, the question and answer section, so we'll be answering those at the end of the lecture. Next is my pleasure also to introduce Dr. Osama Al-Muqbil. He's also a dear friend of mine, a consultant cardiology, specialized in echocardiography, advanced heart failure, and transplant cardio-oncology. Dr. Aslan also was a cardio-oncology. We have a theme of cardio-oncologists today. And he is also a colleague of Dr. Raslan in the King Saud University, head of the Heart Function Clinic. And he's also the current cardiology fellowship program director, and all his fellows passed the board exam, I think, a couple of days ago. So congratulations to them. And he will be talking to us beyond quadruple therapy. So now we established that the quadruple therapy are important, but do we have any other tools that we can use in our patient, especially if they have any special circumstances? So the floor is yours, Dr. Osama.
Great. Assalamu alaikum. Thank you so much, Dr. Ibrahim, for the nice introduction. And thanks, Dr. Ismail, for really setting the stage for me to take over this beyond what Dr. Ismail just mentioned. So I'm just going to start with a case. Again, it's another case from our clinic with a plateau, and I don't like stable HFrEF patients. I believe they are not that stable. So the patient is a 62-year-old male, similar to the case Dr. Ismail presented, with ischemic cardiomyopathy and severe LV systolic dysfunction with EF of 25. He's not very active, but remains symptomatic with minimal exertion. He's at NYHA function class 3. He's able to walk to the mosque, but he has to stop sometimes to catch his breath. He had 2 heart failure hospitalization over the last 6 months, and he's been referred to heart failure clinic for optimization. So his current medication include aspirin, baby aspirin, sacubitril valsartan, Entresto, a target dose of 200 BID, carvedilol, a target dose of 25 milligram BID, spironolactone 25 milligram daily, Lasix 40 milligram BID, amlodipine 10 milligram daily, empagliflozin 10, bioglitazone 30, alogliptin 25, atorvastatin 40, naproxen, PRN, and coenzyme Q10 and vitamin A as a supplement vitamins. His vitals, blood pressure of 105 over 35, heart rate of 78 beats per minute and regular. He's volemic by physical exam. His labs include a hemoglobin of 12.1, a ferritin level of 65 with a TSAT of 18. His creatinine is normal at 84 with normal sodium of 136 and potassium of 4.6. However, elevated NT-proBNP at 5,500. His ECG shows a normal sinus rhythm with narrow QRS at 75 beats per minute. His echo shows a dilated LV with severe systolic dysfunction at ejection fraction of 25, moderate diastolic dysfunction with high filling pressures over normal RV size with no significant valve dysfunction other than elevated estimated RVSP at 50 to 60 millimeter mercury. So the question now, he's on the fantastic 4 that Dr. Ismail just mentioned, try to convince us, life is good. However, this patient, I don't think he's optimized. So I just want you guys to, pause for a few seconds, try to send us some ideas how to optimize his care. I'm just going to give you maybe half a minute. If you can, just write down any things that you can do to optimize his care. And maybe Dr. Ibrahim, if you can see if they are on the right path, just to test what the people think before we start the optimization process. Okay, so I see some people.
But you mentioned isobide.
Okay, that's a good one. Anything crazy? I'm really surprised. Okay, getting more.
ICD, somebody's mentioning.
Oh, wow. Cool. Another 10 seconds. Hopefully the fellows who passed the exam are attending. I will see if they vote for other things. 5 seconds. 4, 3, 2, 1.
There is
Any last?
Amna mentioning IV iron, stop
Okay.
pioglitazone, consider ivabradine, assess ICD-CRT, advanced heart failure referral. So like a
Wow,
thorough.
that's a fantastic answer. Yeah? Okay, perfect. So that's good. So we're gonna start optimizing his care. It's a lengthy process, so bear with me. So the target, hopefully by the end of this half an hour, is for you guys to be able to recognize what we mean by plateau HFrEF patient, despite the optimal quadruple GDMT. Then identify candidate for adjuvant therapy, including ivabradine, digoxin, digitoxin, vericiguat, IV iron, combination of hydralazine, azosubate dinitrate, and polyunsaturated fatty acids. And also not to forget non-pharmacological class 1 Dr. Ismail mentioned, including cardiac rehab, vaccination, and make sure you stop harmful drugs that might sabotage your care in such patient. Then hopefully at the end, we can build a practical optimization plan to our patient to make him less symptomatic and with less frequent hospitalization to improve his outcome. And my lecture is basically based on recent guidelines, including European, American, and Saudi heart failure guidelines with updated, focused update a few years ago, and some clinical trials. We're gonna move over them in the next few slides. So why do patients plateau on quadruple therapy? These are some common reasons why patients, despite GDMT, despite all the Fantastic Four, they remain symptomatic, including residual risk, including comorbidities, including some, unfortunately, bad drugs and harmful drugs. And sometimes we look for them as one size fits all, which is not the case all the time. And I'm sure my colleagues share with me this as well. It's not everything, can work for this patient. Probably you have to phenotype them. So you have to recognize the triggers, including non-steroidal anti-inflammatory drugs, TZDs, high sodium intake, which is very common in our population, poor adherence, hidden infections, UTI, especially with this GLT inhibitor. Don't forget the residual tachycardia with a heart rate of more than 70 despite maximum tolerated beta blocker. Iron deficiency, as mentioned by the audience, with or without anemia. This leads to decreased, exercise tolerance similar to our patients with frequent hospitalization. And also keep in mind the worsening heart failure phenotype with recent hospitalization requiring IV Lasix, as these are at very high risk phenotype. And always don't overlook underutilized class 1 recommendations such as cardiac rehab, vaccination, and multidisciplinary heart function clinics, with a pharmacist and dietitian and other allied healthcare in your clinic. And keep in mind the bill burden, especially in our populations who really likes, to get the minimum discount or the maximum discount and the minimum pills as possible. This is shown by my colleague, Dr. Ismail, and I agree with him 100%. We love this diagram because it really shows you the journey of a heart failure patient. And most of the time, which really kills me when, someone sees the patient in the clinic and they believe they are at low risk or, they are stable, quote unquote, without, further optimization of this care. So as you can see, when they diagnose, they are at elevated risk, then they start, their quadruple therapy, GDMT, as Dr. Ismail mentioned, the risk goes down but never reach zero. There is what we call the residual risk and opportunity for optimization. And with every hospitalization, patients deteriorate with worsening events and increasing clinical risk. leading to advanced heart failure risk, as Dr. Ismail mentioned. So first of all, you really have to delist medication, stop the bad medication. This includes the medication that has no benefit as a class 3, such as in our patients, the dihydropyridine calcium channel blocker, and the vitamins and nutritional supplements and hormonal therapy. And also you have to really stop and trash the harmful drugs, including the rapamycin, the non-dihydropyridine calcium channel blocker, the class 1C antiarrhythmic, the TZDs, the saxagliptin, the alogliptin, and always the non-steroidal anti-inflammatory drugs, which our population don't believe they are a medication. So starting to stop the harm, stop the non-steroidal, because this leads to fluid retention, sodium retention, renal vasoconstriction, acute kidney injury. And as I mentioned, patients don't count them as a medication. They think they are analgesics. So that's why you really have to dig more, asking the patient specifically, do you take this medication or not? Do you take any analgesia or not? And always don't forget herbal medication, which our population always not consider them as medication. Again, bioglitazone leads to frequent heart failure hospitalization and fluid retention. Verapamil, diltiazem is a no-no. It's a class 3. You really have to stop them. And again, don't forget decongestant, high sodium over-the-counter medication and supplements, because they might worsen your patient's stable condition. So in our patients, we stop naproxen, we switch them to a heart failure safer medication such as acetaminophen. We stopped the bioglitazone. Actually, in fact, he was taking a combination of a bioglitazone and alogliptin. And honestly, since he's been taking this medication, he had these frequent hospitalization. So we really have to stop the bioglitazone and alogliptin and consider switching them to more cardiac safe medications such as GLP-1 receptor agonists. And again, you really think about the vitamins the patient is taking. Is it really necessary? Are they treating a deficient vitamins or just a supplements? And only keep them as necessarily. And again, recheck medication, herbal, and all that stuff the patients can take. And sometimes duplication medication, sometimes they're taking the same medication from the same class. So you really have to delist such medication, which I think is very important and crucial. After that, you target the heart rate. In our patient, if you remember, the heart rate was more than 60. Why heart rate matters? Because with every single beat you decrease the heart rate of patients with HFrEF, you decrease their hazard ratio. This is the hazard ratio of patients with a heart rate between 60 and 70 is 1.2, and you can see the hazard ratio increase to 1.9 when their heart rate is more than 80. And these, when the least patients to have recurrent heart failure hospitalizations are those with heart rate less than 63. And that's why we're talking about ivabradine. And ivabradine is basically indicated in patients with symptomatic chronic HFrEF with ejection fraction less than 35, and sinus rhythm with a resting heart rate more than 70 on maximum tolerated dose of beta blocker. And you start with 5 milligram BID. May you consider 2.5 if there's a bradyrisk for bradyarrhythmia. And you titrate every 2 weeks to maximum tolerated dose of 7.5 milligram BID to target a heart rate of 50 to 60. Why we're doing this? This is basically from the SHIFT trial, which basically included patients with the same inclusion criteria just mentioned. They randomized them into ivabradine versus placebo, and the results were decreased composite endpoint of cardiovascular death or heart failure hospitalization, mostly driven by heart failure hospitalization, but definitely something to consider in our patient. And keep in mind some adverse events, and I think Dr. Abdeshafi is going to go over them in more details. So it made it to the guidelines. It's the class 2A recommendation now for such patient to be on ivabradine because if their heart rate is more than 70. Always confirm they're in sinus rhythm, avoid it in AFib, make sure the resting heart rate more than 70 with a stable status in terms of euvolemia, and there's no severe renal impairment or hepatic impairment, and make sure you review the medication for interaction. And then I'm going to leave the rest for Dr. Abdeshafi to talk about. Next is digoxin, old but gold, or probably not that gold, maybe silver nowadays. So it's been, after the DIG trial with no mortality benefit, not that much used in nowadays, especially with, fundamental quadruple fantastic therapy. Mechanism of action for digoxin is basically a cardiac glycoside that it works through the sodium potassium ATPase inhibition to increase your intracellular calcium to increase inotropy, then works on increasing vagal tone by decreasing the heart rate. which leads to a neurohormonal modulation, very favorable, however, has a narrow therapeutic index, and that leads to really not much uptake in using digoxin nowadays in the modern era. When to consider it, when the patient has persistent symptom despite GDMT, especially with recurrent admission, with a low borderline blood pressure, and cannot use further vasodilation because of this soft blood pressure, especially in concomitant AFib, because basically going to hit two birds with one stone. Dosing, you just start with low dose and you target the serum level of 0.5 to 0.9 to avoid risk of arrhythmia and electrolyte imbalance. Make sure you keep the potassium high, magnesium high, and monitor your QT and make sure you review the medication to avoid drug interactions such as amiodarone, verapamil, and macrolides. Toxicity presents usually with GI side effects, confusion, visual changes, which is not uncommon in patients with renal impairment, especially in elderly female. Moving to digitoxin, which is the new digoxin. What's digitoxin? It's basically similar. It's a cardioglycoside similar to digoxin, but has different pharmacokinetics than digoxin. Popular interest in the recent few months after the publication of the DIGIT-HF trial, which was presented a few months ago at the European Society of Cardiology and published in New England Journal of Medicine. It's been used in patients with on maximum tolerated dose of quadruple therapy with persistent symptom despite achieving good doses of quadruple therapy, including ARNI and SGLT inhibitor, which is something new compared to DIG trial. So it has a potential role in advanced heart failure phenotype, patients with recurrent admission, but make sure to optimize the 4 pillars, the heart rate, the iron, remove the harms before considering digitoxin because it still has same side effects as digoxin. And unfortunately, it's not available in our market yet, but looking forward to having it because I think it's an added benefit to our population. Moving next to vericiguat, which is basically a stimulator of soluble guanylate cyclase to increase the cyclic GMP. This will lead to increase the nitric oxide pathway, enhancing contractility. When to consider this, it's basically in patients with worsening events, as shown in Victoria trial, which was published 6 years ago at New England Journal of Medicine, that showed decrease in the composite endpoint of cardiovascular death and heart failure hospitalization with a hazard ratio of 0.9. This is in patients with persistent symptoms despite GDMT. How about to use it in less sick patients? The Victor trial, which was published recently in The Lancet, showed no benefit in more stable ambulatory HFrEF patients without recent worsening events. And that's why using this drug in the population with worsening events, I think, will pay for the pocket. Adverse events including hypotension, anemia. So that's why you have to monitor the blood pressure and their hemoglobin to make sure they don't develop anemia. Moving on to IV iron, and as mentioned from the participants, you treat an iron deficiency anemia. Why is that? Because it has been shown in multiple clinical trials and endorsed by multiple guidelines to use it when patients' ferritin is less than 100 or a ferritin of 100 to 300, but a TSAT of less than 20. So in our case, our patient has a ferritin level of 65 and a TSAT of 18. So he's iron deficient despite being anemic. So he deserved to get an IV iron. Why it matters? Because patients with iron deficiency has reduced skeletal and cardiac mitochondrial function, and this leads to fatigue, poor exercise capacity, and worse outcome with recurrent hospitalization and poor quality of life. What therapy has been proven is either ferric carboxymaltose or ferric desomaltose. And IV iron is the way to go because all the trials for oral irons unfortunately failed to show any benefit in heart failure with reduced ejection fraction. So this has been endorsed by the European guidelines, by American guidelines, and by our Saudi guidelines to use it to alleviate the symptoms, improve quality of life, and to decrease heart failure hospitalization in patients with iron deficiency. Moving on to cardiac rehab, it has a class 1 recommendation, however, underused in most cardiac centers. It definitely leads to improved function because, as you know, heart failure is not just a pump failure, it's a skeletal muscle dysfunction, deconditioning, such as in our patients who's really deconditioned and unable to really make his walk to the mosque. Exercise training is known to improve peak VO2, quality of life, and functional capacity. When to consider exercise and cardiac rehab in stable HFrEF patients once they are stable and quote unquote stable and euvolemic. And it's really particularly helpful in frailty in active phenotypes such as our patient. This evidence is supported from the Ejection trial since 2009, which basically tested structured exercise training in patients with heart failure and reduced ejection and showed it's safe. It's really provide a good reduction in clinical events and quality of life benefit. And that's why it's been recommended now by all guidelines to use exercise rehab as a class 1 recommendation, especially, using it in a supervised 3 times per week with some resistant training, and make sure you educate the patient about self-care, doing it with psychological support to really encourage them to do it as often as they can, because definitely it makes a huge difference in their compliance and in their day-to-day activity. I'm now moving to another non-pharmacological optimization opportunity that's always been missed in unfortunately sometimes. So vaccination is a class 1 recommendation as well. Why is that? Because as you know, respiratory infections leads to triggers of acute decompensation, which is very common nowadays, and that's why we have a lot of acute decompensation heart failure admission nowadays, because of this is the season where we have flu and upper respiratory tract infections. And unfortunately, and that such inflammations leads to myocardial stress, arrhythmia, and this is basically a viscous cycle. You can prevent it by vaccination, then that's class 1 recommendation for your patient. Keep in mind annual influenza vaccine, pneumococcal vaccine, and COVID-19 vaccine as well. Again, all recommended in high-risk patients such as heart failure. Again, endorsed by guidelines, recommended as class 2A. Some guidelines make it class 1. Again, take-home message, vaccination is a low-cost, system-level intervention. It definitely reduce hospitalization for patients with heart failure. How about polyunsaturated fatty acids? Basically, it has class 2 recommendation based on the GCHF trial, which is basically a randomized placebo-controlled trial, included 7,000 heart failure patients with NYHA class 2 to 4. It has a small but significant reduction in mortality when you give them polyunsaturated fatty acids. And I take it, to be honest with you, as an opportunity to just delist medication from the patients of all these vitamins. If you really want to take a vitamins, then probably this is the vitamins you really have to take. And the dose is 1 gram per day of polyunsaturated fatty acids. And make sure you monitor GI side effects, because it increases GI intolerance and sometimes increase bleeding risk, especially in patients taking anticoagulant. Again, it's a modest effect. Probably as a practical point, prioritize the higher impact medication we just mentioned, such as ivabradine, digoxin, digitoxin, iron, berzoquat, cardiac rehab, and vaccine before you move into polyunsaturated fatty acids. Lastly, the one we started with, as recommended by the audience, about hydralazine isosorbide dinitrate. It has a role. However, in self-identified Black patients with NYHA function class 3 to 4 on optimal medical therapy. This is based on the AHIFT trial, which is basically an old trial using ACE and no SGLT inhibitor at the time. So we don't know about the evidence nowadays. Or you can use it as alternative in patients with CKD who cannot take ACE inhibitors, ARBs, or ARNI due to hyperkalemia or due to progressive renal failure or hypotension. How it works? By decreasing afterload and decreasing preload. So hydralazine decrease or afterload, nitrate decrease or preload. And it comes in combination. And if it doesn't come in combination, then unfortunately you have to give it as separate doses, which is again a burden of polypharmacy on the patient. Especially you have to give it TID, which is again a burden on the patient. So it's not really a favorite thing nowadays. So this is my algorithm to optimize patient care beyond the 4 pillars. It's a practical about, tackling phenotype, not checklist. And again, I started with step 0 because this is what Dr. Ismail mentioned. You really have to start with foundational therapy, ARNI, ACE, ARBs, beta blocker, MRA, SGLT inhibitors, and make sure the patients reach the maximum tolerated dose achievable before you move to step 1 and 2 and 3. Step 1 is to stop the harm, which is, I think, crucial. But as I mentioned earlier, our population don't like using a lot of medication. So if you can delist them, like in our patients, we stop at least 3 medication, stop non-steroidal, stop TZDs, stop calcium channel blocker, stop all these supplements, and make sure you audit their medication. I always ask, it's a standard hour actually clinic to ask the patient to bring their medications with them so we can counsel them about which medications they're taking. And sometimes, as I mentioned, they take 2 medications from the same class because it's different companies. So stopping the harm, I think, is crucial, comes as step 1. Step 2 is phenotype your patients to add on therapy, especially now you have room because you stopped all the harm. If the heart rate is more than 70 in sinus rhythm, then add ivabradine. If the patient has persistent symptoms, AFib with low blood pressure, consider digoxin, digitoxin when available. And if there is any recent worsening heart failure events, consider vericiguat. If the patient has iron deficiency with a ferritin less than 100 or TSAT less than 20, then give them IV iron. Then make sure you don't forget class 1 non-pharmacological therapy, which works like magic, cardiac rehab, vaccination, and multidisciplinary heart failure care with counseling and encouraging patients to take their medication because it works. Lastly, back to our case, make sure you maximize the benefit while minimizing side effects and bill burden. So we prescribed his medication that he's taking for harm or no benefits. We stopped the naproxen, we stopped the pioglitazone, we stopped the allogliptin. We rationalized amlodipine because his low blood pressure, I don't think he needed amlodipine, and the supplements were definitely stopped because there is no evidence, and actually it's a burden on him. We treated his phenotype because heart rate was more than 70. We gave him ivabradine 5 milligram BID, targeting a target dose of 7.5 milligram to a heart rate 50 to 60. We corrected his iron deficiency because his ferritin was low. Give him ferrixic albimactose. And because of the current hospitalization, he's been considered for vericiguat because of the worsening heart failure event. Might consider digoxin if the patient blood pressure is soft or AFib, similarly for digitoxin. And again, enroll him in cardiac rehab, update his influenza and pneumococcal vaccines, and close heart failure follow-up. Maybe consider polyunsaturated fatty acids if patients is really interested in taking supplements and vitamins. Make sure you follow him to make sure this medication works and he's decongested and he's adherent, no side effects. Make sure you monitor the renal function, your potassium level and hemoglobin and iron indices after the infusion. And again, titrate to target, ivabradine targeting a heart rate of 55 to 60, vericiguat, basically the target dose is 10 milligram daily. Potassium, the serum level and the serum potassium to make it more than 4. And make sure you watch interaction anytime the patient takes any antibiotics or any new medication. Make sure you monitor their TH level so they don't go into toxicity, especially with advanced worsening renal function. Lastly, take-home message. Again, beyond the 4 pillars, the quadruple therapy are the foundation. However, it's not the finish line. Heart failure progression reflects really a residual risk with worsening heart failure risk over time. Always remove the harm in non-steroidal TZDs, calcium channel blocker, and other supplements, and address the triggers and phenotype your patients if they are if with heart rate is more than 70, add ivabradine based on the shift. IV iron deficiency, add IV iron. Recent worsening, add vericiguat. Resistant symptoms, add digoxin or digitoxin. And don't forget class 1 recommendation, cardiac rehab, vaccination, and multidisciplinary follow-up. And again, modern heart failure care is about precision, is about phenotyping your patients, not one size fits all. Thank you.
Thank you very much, Dr. Osama. It's a very impressive, comprehensive review of the non-GD quadruple therapy GDMT for FRF patients, and you can see like we have a lot of tools right now that we can utilize. Still did not mention even device therapy, valve intervention, all the other non-medical therapy. And that's been a great advancement in the heart failure therapy in the last few years. And I think that's probably will trigger one of the questions later on about the role of heart failure specialized service, given the advances that's happening right now and how much we can offer the patient to progress into the management of this disease. So we'll keep, as we mentioned, question and answer until the end. We have almost 300 participants, so please, if you have any question, type it in the Q&A box so we can answer it at the end. Then I will move to also my colleague from National Guard Hospital in Riyadh, Dr. Muhammad Abdel Shafi. He has a vast experience, more than 25 years in cardiology award. He has a very a great interest into heart failure and advanced heart failure. I shared with him the podium in multiple occasions. He also currently chairing the cardiac clinics in the King Abdulaziz Cardiac Center in National Guard Hospital in Riyadh. And he will be talking to us about a specific medication that we usually use in heart failure rate control, which is called ivabradine. It was touched base upon briefly by Dr. Ismail and Dr. Osama, and Dr. Muhammad will give us more details about ivabradine in the next 15 minutes. And the floor is yours, Dr. Muhammad. You're mute, Dr. Muhammad. Dr. Muhammad, you are on mute.
Okay, you can hear me now?
Yes, now we can hear you.
You can see my slides also?
Yes.
Okay, thank you, Dr. Ibrahim, for this nice presentation. Thank you also for Dr. Aslan and Dr. Mokbil for this great presentations. It made my life very easy, actually. I'm talking about something specific, controlling the heart rate by ivabradine in heart failure. This meeting, as you know, it's sponsored by Servier. Just this will be my content, heart failure burden, just 2 or 3 slides. Importance of reduction of heart rate in hospitalization, also on survival improvement after heart rate control, ivabradine role in heart failure, and some guidelines. And I will finish by my conclusion. I will start by just 3 questions, just MCQ questions. What is the main mechanism of action of ivabradine? Is it selective inhibition of beta-adrenergic blockers, inhibition of calcium influx to myocardial cells, selective inhibition of IF current channel, sinoatrial nodes, or inhibition of late inward sodium current? Just for the audience to think about the mechanism of the action. So the answer is C.
A lot of people saying C.
Yeah. It's okay.
They're good listeners.
You want me to wait for them to answer or just continue?
They're already doing very well, so yeah, you can.
Excellent. This, of course, this is a mechanism of action of ivabradine. It acts on what's called finite channels in the SA node. So it prevents usually the exit of potassium from the SA node. So it prevents the process of depolarization. So it delay the discharge of the impulse from the SA node. So it leads to decrease the heart rate. This is a specific mechanism which is specified for the SA node. In patient with a heart failure, either this patient in beta blocker or not, if you want to start ivabradine, when to start? If the heart rate above 50, above 60, above 70, or above 80? This answered many times by Dr. Osama in his slides. Of course, we'll start when the heart rate above 70. This is by the guidelines. The last question just is, which of the following condition is a contraindication of the use of ivabradine? Is it mild hepatic impairment, well-controlled hypertension, decompensated heart failure, age over 75? This is very important, by the way. So the answer is also C, decompensated heart failure. If you have admitted a patient decompensated in your hospital, you cannot start ivabradine until you stabilize your patient. Just about heart failure burden, as Dr. Aslan said, about 60 million all over the world. It's one of the most common epidemics. It's the most common cause of admission for those above 65 years. Every year, 600,000 diagnosed in Europe and the States. One of 5 of the heart failure patients die within 1 year. Any patient, heart failure patient, usually they have 4 admissions at least in their life, with the mean cost of the single admission $22,000. So it's a very heavy burden disease. And as you know, it's a progressive disease. The more that you get attacks and heart failure admissions, the more the worse the prognosis. This is the mortality regarding the heart failure. This is during the hospital admission. It's 4 to 7%. In the first 2 months or 60 days, is 20 to 30%. In the first year, the mortality is 20 to 30%, and the 5-year mortality is 50%. So it's a very, very killing and lethal disease. Not only that, for those patients who are admitted early, they have the higher mortality is very high. Look for is very low. So usually we try to avoid also not only the mortality, to avoid the hospital admission. Also, this is a very nice slide. We saw it many times. Those people are interested in heart failure, that heart failure is more common than the most common cancers in the females and the males. So just to show you how the disease is killing those people who are suffering from heart failure. The problem for the management of heart failure is not easy, as Dr. Osama said. It needs a lot of issues, a multidisciplinary team. So you need to stick to the guidelines, to the 4 pillars of drugs. You have to see the patient every 2 weeks for up titration of this medication. Also for the disease managed, it needs a specialized heart failure team to manage those kind of patients. Not only that, those people for heart failure, 40% of those people, usually they have more than one comorbidity. They have renal failure, they have diabetes, so it's that the management of them is very complicated. Also, 20 to 50%, they have more than 10 pills per day. So there's a great problem of adherence for those group of patients. 50% usually are readmitted after 6 months. So the management for those group of people is not easy also. Not only that, usually they have a problem. The heart rate is to keep it above 70 or to keep it less than 60. So some people, they have heart rate of 100 or 110. How you can take this rate down? For also those people, 50% of heart failure people also, they have chronic kidney disease. This will make a problem to start the ARNI and RASI inhibitors because of the problem also of hyperkalemia. Also for the blood pressure, usually those people of advanced heart failure, they have low blood pressure. It's not easy to manage this with these drugs that lower the blood pressure. 50% of heart failure patients, they are suffering from atrial fibrillation. So it's another problem. So the management, as I said, of this group is very complicated and need expert. What about the heart rate? If the heart rate matters in heart failure, we'll see now. Usually, in case of elevation of heart rate, usually you have increased the process of atherosclerosis, endothelial dysfunction, oxidative stress, plaque instability, arterial stiffness will increase. Also, ischemia will happen due to increased oxygen demands. This will lead a process of remodeling and cardiac hypertrophy. Also, this will lead in the end with chronic heart failure, increase oxygen demand, decrease ventricular efficacy, and also decrease the ventricular relaxation. So the heart rate is a very important to be controlled for those group of patients. For different trial of heart failure like DAP heart failure and liver heart failure, we found that those group of people, they have heart rate from 70 to 75. Usually they have better mortality or they do better than those usually they are discharged with heart rate above 80. Also regarding the worsening of heart failure admission, those with heart rate less than 60 or less than 70, they do better than those discharged with a very heart rate above 80. Not only that, for the GC trial, that usually published 1999, 6-month mortality for those post-MI survival, those discharged with a heart rate less than 60, the mortality was 1.9%. While look for those discharged with a very high heart rate, 100, above 100. The mortality, 6-month mortality was 20%. So even in MI, heart rate or ischemia is a matter also. This from the Ascent trial, you can see that 80% of the patient had a heart rate above 70, despite of most of them were in beta blocker. And you see that those people usually have heart rate above 70, they have higher mortality than those group that usually they have heart rate less than 70. This is a very nice registry, Norwegian registry. It's about 2,600 patients. We found that 95% of those people were in beta blocker, while 1 of 3 of these patients, 30%, the heart rate was not controlled. And this inversely will be reflected on the mortality for those group of patients. This just to remind you with what my colleague said about the pillars, the 4 pillars of heart failure, about the RACID, about MRAs, LG2, the beta blockers. These are very important drugs, decrease the mortality a lot, decrease hospital admission. Is it matters? Yes, because you can see that those patients who are untreated, the mortality was 17%. If you give the 4 pillars, the mortality decreased, the 1-year mortality from 17 to 4%. But if you control the heart rate less than 70, the mortality again decreased from 4.7 to 4.2%. Just few slides about SHIFT trial, because it's a very important trial published 2013 about the control of heart rate in heart failure with reduced ejection fraction. This was 6,500 patients from usually symptomatic from class 2 to 4, ejection fraction less than 35%, heart rate above 70. The mean follow-up for those group of people was 3 years. The primary endpoint was cardiovascular death or hospital admission for heart failure. You can see that for those people who are receiving the ivabradine group, the mean heart rate decreased just after 2 weeks, decreased and stays stable all over 32 months, was 67. While those in placebo, by the way, those people were in beta blocker. Those people, the heart rate was 75. Not only that, also, those people, they have heart rate less than 60. They did the best. That's why Dr. Osama said, just keep the heart rate from 50 to 60. For those people, as a subgroup analysis, less than 60, they do the best. And just to try to keep those people in this range from 50 to 60. So for those people taking ivabradine in this trial, there is decrease in the heart rate by 14%, while in placebo 5.8 were very significant p-value. Also for this reflected on the left ventricular systolic and diastolic end volumes. So this decreased by 7 mil, and for diastolic decreased by 8 mil. In comparison to the placebo, which almost not decrease, and this will also was very significant p-value. This will be reflected by decreasing the volume, will be deflected, of course, on the ejection fraction. So you can see for the on discharge, the ejection fraction, the mean was almost the same. It's almost 32. While after 4 months, the group that received ivabradine and with control heart rate, the heart failure start to improve to 44%. The ejection fraction start to improve to 44%. And after 1 year, the group on beta blocker, 41%. And those with control heart rate with ivabradine and beta blocker was 48%. Not only that, also regarding the quality of life, for the 6-minute walk, for those on carvedilol, it's 62. The 6-minute walk was 62 meters, while after 4 months, those who are receiving ivabradine and controlling heart rate, the 6-minute walk improved to 116 meters. So it's reflected on the mortality, reflected on the quality of life and everything. Let's see the admissions. As we said, the admission it matters also. So the first admission for those group taking ivabradine, all this favors ivabradine group. So the ejection fraction, the first hospital admission decreased by 20%. The second hospital admission decreased by 34%. The third one, or the third hospital admission, decreased by 29%. This for the favors to the ivabradine group in comparison to all the standard therapy. In general, decreased the hospital admission by 25%. So 26% we have decrease in the first hospital admission. As we said, the first hospital admission is usually, it comes early, usually it associated with a very high mortality. For regarding the improve the morbidity and heart failure mortality, also for it favors of the ivabradine arm by 18%. So ivabradine plus beta blocker, it's very tolerable, decrease the heart rate, increase the stroke volume. There is no effect in the cardiac output. There is no effect also in the blood pressure. This is the reverse of the beta blocker that can affect cardiac output and can affect the blood pressure, especially for those patients with advanced heart failure with very low blood pressure. So in case if you have a patient with heart failure, ejection fraction, very low, like 15 or 10%, and you have a very low blood pressure, you cannot start beta blocker, but at least you can start ivabradine because it does not affect the hemodynamics. That's why in the guidelines, as Dr. Osama said, it's class 2A for those symptomatic heart failure patient with reduced ejection fraction, less than 35%. And they are in complete guideline-directed medical therapy with heart rate above 70, it's indicated to prescribe ivabradine for those group of patients, either the patient or beta blocker or cannot tolerate beta blocker. Regarding the Saudi guidelines, of course, my colleague, they know this better than me. It's the same. You have to start the guideline-directed medical therapy and you check the heart rate. If the heart rate still above 70, ejection fraction less than 35, sinus rhythm, the patient is still symptomatic, you can start ivabradine. This is a very important, the ivabradine checklist. Before you start, you have to make this checklist. So the patient should be stable, should not be in cardiogenic shock or advanced heart failure or still symptomatic. Systolic dysfunction, ejection fraction less than 35, heart rate more than 70. The patient should be on all the guideline-directed medical therapy and should be on the maximum tolerated dose of beta blocker. For the safety for the check, there is no contraindication except for those severe hepatic impairment or cardiogenic shock, pregnancy, or lactation. Or the patient is taking drug that usually needs these enzymes to be enzyme inhibitor, those like verapamil, diltiazem, or ketoconazole, because usually there is a sort of competition about metabolism. This might lead to increase the level of ivabradine. So in those group of drugs metabolized by this cytochrome B, so you have to avoid those group of drugs or use the use of ivabradine with those group if these drugs are a must. For monitoring of the dose, as Dr. Osama said, you can start by 5 or 2.5 for the very old people elderly above 75, and you have to titrate the dose every 2 weeks, and you have to monitor for AFib and QT prolongation. Also, we have to educate the patient about some side effects that may resolve spontaneously, like fatigue, palpitation, or dizziness. Just to complete the picture, what are the side effects? This is my last 2 slides. The side 10% usually they have bradycardia. And this usually happens in the first 2 and 3 months, and you can make it by adjusting the medication and close monitoring of the patient. When you start the drug, you have to bring the patient within 1 or 2 weeks to see the heart rate of this patient. For the heart rate may change. Some of the people, they got atrial fibrillation. In this situation, you have to stop the drug and restart again if the atrial fibrillation resolve. For the nervous system effect, headache sometimes happens. Also, what's called luminous photosensitivity. Some people usually they see like white halos in the beginning, first 2 or 3 weeks. This usually because the same receptors, HCN receptors present in the retina, and usually this is respond to decreasing the dose, or it can resolve spontaneously within 4 to 5 or 6 weeks. Also regarding that may happen for 1% side effects, GIT manifestations, physical symptoms, muscle cramp, fainting, some skin reactions, which usually self-limited, and 1/1,000, usually urticaria can happen, which might happen very, very rare, 1/10,000, sick sinus syndrome, or any type of heart block that can happen. So in conclusion, High heart rate is a risk factor of cardiovascular disease and hospitalization and for the mortality for the heart failure. Guidelines recommend to reduce heart rate less than 70. If it's less than 60, it's well and good. Heart rate control below 70 beat per minute reduce the hospitalization and also reduce the mortality and improve the survival. If symptomatic patient with heart failure with reduced ejection fraction, we need ivabradine as soon as possible to control the heart rate to prevent the early readmission or to prevent the mortality that might happen later. Ivabradine facilitates the beta blocker up titration combination in the possible standard therapy for heart rate control and related heart failure outcome. So keep your heart safe, please, and keep your heart always green, as we said, green and young. Thank you so much for this few minutes that you listened to me. Thank you so much.
يعطيك العافية دكتور محمد. We enjoyed alhamdulillah 3 great lectures. It was nice to نختم زي ما يقولوا ختامها مسك. And now we have the question part. So before that, I will just a brief points about the registration CME hour. So basically, if you registered at the beginning and the link sent to you, once you log in with this meeting with the same email, automatically you will get the CME hour. So you don't need to do anything extra. And as I mentioned before, this is the first of a series of webinars. Inshallah, probably we'll reach 6 or 7 this year. All will be CME accredited. So please follow the Twitter handle or the X handle at Saudi_HFS, Saudi_HFS Heart Failure Society. So you can get updates on the webinars once they are announced, and you can register early. The seats we already reached 300 attendee today, and that's a good start for our series of webinars. So to kick with the question, I think there is a couple of questions in the chat, but I will have a question for Dr. Aslan, and then I will ask the question from the chat. You mentioned in one of your slides the gap in the initiation of GDMT. Like we know, heart failure patients are a sick group of population. You see the curves that everybody is mentioning. The mortality is not good, so we need to start those medication. We know that they're working, but we don't achieve this amount of initiation and titration. Those numbers are from international data. I don't know if we have any local data, but from your point of view, locally, from your experience right now, participating in the hospitals and university, private sector, what are the reasons that preventing people from initiating and titrating in our community? So we can have maybe a greater insight on how to tackle it.
Thank you, Brahim, for your question. And I'd like to start off by thanking my colleagues for their excellent presentation. I genuinely enjoyed sharing the stage with you today. You know, you tackle an important question, and this is something that gets repeated over and over again. There was a very nice survey that was published about 3 years ago that looked into whom are the people who are likely to intensify GDMT. And as we would expect, the most likely people are the heart failure cardiologists, followed by the cardiologist, and then there is a reduction in uptake from the general practitioner. And there's this inertia where it seems that the ownership of this GDMT seems to fall under the heart failure cardiologist, which is not necessarily the case. You know, this is one of these very fine examples where if you see something, say something or do something about the situation. So a lot of the times chatting with our colleagues from the family medicine, when we go for outreach programs, the first comment that comes up is, you know, the heart failure doctor did not raise the bisoprolol or the beta blocker. Why should I do that? Or the patient is not an SGLT inhibitor. Maybe there is a reason that the cardiologist did not do that. So I think that's part of the issue. But the other thing is, you know, there are these referral pathways, and we've talked about this before about a spoke and hub model. And sometimes it's not very easy to get access to a specialized heart failure consultant. And I think that's why it's very important to know that we share the care, but we also share the responsibility when it comes to ensuring that we put our patients on the maximally tolerated GDMT in the fastest, safest possible manner.
Excellent, Dr. Ismail, and maybe I will go to Dr. Osama next. You mentioned clearly a lot of other things that need to be to be given: the Vericigua, the Ivabradine, the Digitoxin slash Digoxin, and the vaccination, cardiac rehab. Still, we did not touch base on the devices, the revascularization, all those stuff. So, how are you finding time in your busy clinic to go through the whole checklist of things? And is that because practically speaking, for example, in the governmental sector, we don't have only 15 minutes for patient, we have overbooking. So you probably see two patients in the same 15 minutes, or in the private sector, it's the same thing. So are you able to do that in real life? And if not, all the time, what do you think we should do as a heart failure community in the bigger picture for to implement all those changes or all those great suggestions that you're mentioning in your lecture?
Yeah, that's very, very informative and good question. And to be honest, I think it's very practical because you mentioned all the things I mentioned, and I agree with you. Finding the time is not easy, especially in a busy lifestyle where you really have a lot of patients, as you said, overbooked, and a lot of patients. Honestly, I spend a lot of time convincing patients to take their four pillars, let alone taking additional therapy. So it's not easy. I agree with you 100%. But I think honestly, if delegation, and I think the thing I mentioned at the end, having a heart function, clinic or heart function service, I think definitely helps because, the pharmacist is going to talk to the patient about the polypharmacy, why not you're not taking this medication, why you should stop this medication. So all the things I mentioned as step zero or step one, I think it would be done by the team. Then you focus on the fine tuning, phenotyping the patient. This patient has recurrent hospitalization. I like to, and again, I think I share the same thing with Dr. Ismail. I like to screen the patient before the clinic. So usually go to the day before. I see who's coming. Okay, this patient, he's missing this medication. He's missing this vaccination. I think there is a role for optimization in terms of rehab. This patient might be a good candidate for such study where we can enroll him in cardiac rehab, enrolling him in IV iron, enrolling him in a CKD trial. So definitely, pre-screening, delegation, how function service, where the whole team can really help. Also we, and Dr. Ismail also have, the WhatsApp account where patients can reach us to us, ask their question. We spread information to them about Ramadan, how to fast and what to do with your medication during fasting. So this will really save the time where, instead of explaining this to the patient in the clinic, you focus on really fine tuning and making sure you target the high-risk patients with a targeted phenotypic therapy.
Excellent, Dr. Osama. And Dr. Muhammad, you mentioned nicely about the Ivabradine and the shift trial. Um, uh, Practically speaking, like in your patients, do you think most of our patients we like are able to, if the patient is coming to you with a lower blood pressure, heart rate in the fast, actually, I'll mention it this way. Who are the patients that you start, for example, Ivabradine early before you start the beta blocker in the maximum dose, or you anticipate you're gonna do like Ivabradine gonna help you optimize the GDMT?
Actually, regarding the heart rate, usually we try even to adjust the heart rate, especially for advanced heart failure patient, even during the inpatient. So sometimes we start ivabradine during the inpatient, but we try to give the patient even a small dose of beta blocker if he can tolerate. If he can tolerate, we just share the ivabradine with beta blocker. But if the patient cannot, usually start ivabradine, and actually it gives me a very good results for those controlling heart rate of those kind of patients. As Dr. Osama said, usually it's a pre-screening clinic. If the patient is coming to you, you pre-screen the patient, you write your notes just and save it and see why this patient is not taking beta blocker. He cannot tolerate the blood pressure, the previous visit with 80. So usually when you have a ready, like a plan ready before the patient comes, this will save time for the patients. Regarding also our hospital in National Guard, of course, you know that we have nurse clinic. We have 8 nurses dedicated for heart failure only. We have 17 nurse clinics, 8 for heart failure. Each patient had at least 30 to 40 minutes time. And then after they make all the detailed management and notes everything. They come for fine tuning, as Dr. Osama said, with the physician. يعني usually we have like eight nurses heart failure and 3 physicians with them. One of them at least consultant. So they have to discuss with the patient, just fine tuning, and then they write the notes and they write the medication for the patients. So this will help. So you are seeing like from 70 to 100 patients per day with these 8 nurses. So this will help us also. If we see a patient in our clinic or my clinic needs a lot of time and is very sick, usually I refer this patient to them so it will have more time. Sometimes I refer the patient for them for up titration medication adjustment, and I'll take him back from them again if I can see him because I cannot see the patient every 2 weeks or 4 weeks, for example. But for them, they can. Also, the role of very important thing that usually I don't think that we have it. We have post-discharge clinic for heart failure patient. Each patient should be seen within 2 weeks. Within 2 weeks maximum to see the patient for up titration medication. This will help regarding the use of ivabradine or regarding the use of other medications.
Excellent, Dr. Muhammad. One question in the chat, and probably I will rephrase it to Dr. Ismail. They're asking about managing patient with HFrEF and CKD stage 3. So probably maybe if you can give us your, like, I know it's a very tricky situation. The cardiorenal patient are usually the most difficult patient, in my opinion, in the clinic. But what's your message to the audience about the quadruple therapy, only the 4 therapy and CKD? Like, do you encourage starting them? When do you stop them, practically speaking?
Okay, so the short answer is when you're looking at heart failure with reduced ejection fraction and CKD, the core message is don't de-escalate heart failure therapy just because CKD is present. Use full GDMT with the thresholds that are available for you, but also utilize tight monitoring. But if we're really talking about CKD stage D, if my memory serves me correctly, that's between 30 and 59. So technically, you are still safe. So if we were to go over all of them quickly, so if you're talking about ARNIs in these patients, you are still safe because you're more than 30. So start low and titrate as tolerated for these patients. Also keep in mind, in any kind of therapy that we're looking into, you are going to get a small creatinine rise after RAS blockade. Monitor it and don't make the reflux to stop reflexively. The other thing is beta blockers are essentially not contraindicated in CKD in these patients, especially when you have a GFR that's more than 30. SGLT2 inhibitors, depending on the type that you use, you can even pull it even lower when it comes to your target. But most importantly, the benefits have been seen in patients with and without diabetes. But most importantly is the kidney protection that you're deriving from your SGLT2 inhibitors and your RAS inhibitors. And the same applies for your MRA. As long as your GFR is more than 30, you should be okay to continue. Even if you're on the borderline and you're willing to, hold your breath for a little bit, you would realize that your creatinine actually improves later on. Like, for example, the guy that I presented for you, the creatinine improved as we pushed for more GDMT. But maybe I can push it a little bit further. So if you have like really bad CKD, your GFR is less than 20, for example, then yes, I at that point would not be comfortable starting RAS inhibitors, MRAs. You would consider, as Dr. Osama has mentioned before, hydralazine, ISDN, and also very importantly, make sure there are no other toxins, as Dr. Osama mentions, that could actually affect your kidney function.
Excellent, Dr. Ismail. Dr. Faiz, do you have a question? I think I see Dr. Faiz Ashar.
Thank you very much for that excellent education program and excellent speakers, and we learn a lot from your talks. And the success that there is no seats. Seats are full and no available seats. That's why I'm here. My question is that the definition of refractory heart failure, is it an undertreated or it is an underdosed? Or what is the best dose for that patient? Is this maximum tolerated dose or guideline directed dose? Because this is usually we have some patients cannot tolerate this guideline directed therapy. So what's your opinion in that definition of the refractory? Yes.
Okay, for Dr. Osama, and we have like 1 minute to answer.
Oh, let Oscar prefers to answer himself. It's very hard question. I agree with you. You know, today's Valentine's Day. It's a love day, man. So it's usually life is good, but it's not always good. I agree with you. Some patients don't tolerate, you know, the medication Dr. Ismail mentioned, the quadruple therapy, and you really you know, sometimes you really have to go to other alternative therapy. And again, that's such refractory, and I think you have to take, you know, again, a step back and ask, you know, whether the patient is taking again a toxins or not, because trust me, most of the time you'll be surprised, and you see it in the KKH, they're taking a lot of medications and a lot of other stuff. So make sure you delist them and try to encourage them why you're not taking their medication. And their, you know, it's again showing them the slide that Dr. Ismail mentioned, show you know, saving life, increasing their, you know, life expectancy. I think encourage them to take the medication. And again, if you are stuck with really a refractory patient, a refractory heart failure, then add the phenotypic, you know, approach. Heart rate is more than 70, add ivabradine, add vericiguat, you know, if the patient having recurrent heart failure hospitalization. And again, encourage them in cardiac rehab and vaccination and all the things I just mentioned. I think it's really underutilized, and you know, takes some effort, but you know, doesn't cost a lot of money.
Excellent. I think we can go on and on forever if we're discussing heart failure with such a STEAM committee and people interested in heart failure and 300 people in the participation, but we have to end it. It's a minute past 9:30, and as Dr. Osama mentioned, it's Valentine's Day, so whoever did not bring anything for his wife, go now and and do some things till you have like a couple of hours in the day. And as I mentioned, you follow the Saudi underscore HFS, so you can have their all of the update about the future webinar. Thank you everyone for coming. Thank Servier for sponsoring this webinar and helping us with spreading the knowledge. Dr. Ismail Raslan, Dr. Sam Meqbil, Dr. Abdul Shafi, Dr. Faiz, and all the participants. And see you inshallah soon for our next meeting.
Thank you so much. Thank you.
Thank you so much, everyone. يعطيكم العافية.
Assalamu alaikum.